Hello everyone. Today we will talk about the meningococcal meningitis, and as it is evident from the name of the disease, it comprises of the two words. One is the meningococcal and one is the meningitis. From meningitis, it means inflammation of the meninges. There are three meninges. Pia mater is connected with the brain. Then comes outside of the pia mater is the arachnoid matter, and lastly the outermost layer is the dura mater. Now, underneath the arachnoid matter and outside of the pia mater is a space which we call the subarachnoid space, and there lies the cerebrospinal fluid. Now, the inflammation of the meninges or these layers is known as the meningitis, and meningococcal is the condition caused by the microorganism which we call the meningococcus, or the name of the bug is Neisseria meningitidis. It's a gram-negative intracellular diplococcus. It has got 5 strains which we name, also called the serogroups. These serogroups are A, B, C, Y and W135. In majority of the cases of the pneumococcal meningitis, it is caused by the serogroup C. These are spread by the droplets, and 40% of the population in the world, they are carrier of the meningococcus in their nasopharynx. But only a very few of these people develop the infection which we call the meningococcal meningitis. Now, there are certain group of the people who are at a higher risk as compared to the others for the development of the meningococcal meningitis, and these are the people who live together in the closed spaces like the military recruits or the hostel dwellers, especially in the student lives, and all those microbiologists who are very much exposed to the Neisseria meningitidis, are the people living in the traveling to the epidemic area, or traveling to the epidemic or endemic area, and also the people living in those very specific area. There are also a group of the people who either have the functional or anatomical absence of the spleen, or a group of the people who have deficiency of the complement. So all these are the group of the people very much vulnerable or susceptible for the development of the meningococcal meningitis. Now, this meningitis develops either as a meningococcemia without meningitis, where we see sepsis all around the body. There can be meningococcemia with the meningitis, or simply the meningitis. That depends upon the virulence of the organism. Now, how these patients present to the hospital? These patients come to the hospital with the complaints of symptoms of the, for example, they may have high grade fever which is associated with the chills. They have nausea, vomiting and abdominal pain. They have body aches, backache, and they may complain of the pain in their extremity or the limbs. Now, patient may be confused, delirious, or may have fits, and ultimately may slide into the coma, which is a state of unarousability. How we diagnose these patients? But before that, we need to also know about the signs which a doctor elicits in the patients of the meningococcal meningitis. There are Kerning signs. There are Brudzinski sign. What is Kerning sign? We first flex the hip of the patient at 90 degree, and then we extend the knee. Patient will feel pain in the hamstring muscle. This is known as the positive Kerning sign, and it reflects the meningeal irritation. What is Brudzinski sign? When we flex the neck of the patient, patient's knee will automatically flex. This is known as the positive Brudzinski sign. Then there are certain petechia, or the red spots, which may be small in size, which may be larger in size, which we call the ecchymosis. And these are mostly in the lower limbs and also at the pressure points. This is again very important to look for these red spots, because majority of these patients, they have disseminated intravascular coagulation along with the meningitis. So how we diagnose these patients of the meningitis? We do the lumbar puncture, we obtain the CSF or the cerebrospinal fluid, and we examine it. Opening pressure is on the higher side. Proteins are on the higher side because of the presence of the bug in the CSF, and because they use the glucose, so glucose is on the lower side. WBC, or the white blood cells, will be on the higher side, around like 1000 cells per microliter, cubic microliter, and the majority of these are the neutrophils. And because This organism is a gram-negative intracellular diplococcus, so it is also present in them. But its absence doesn't exclude the diagnosis. We may need to have the culture and gram staining detection of the microorganism on the CSF. We may also use the urine and oropharyngeal secretions. Now, in some of the patient, we do need to have MRI or CT scan to exclude other problem or the mass lesions, and we also get the blood culture to exclude the sepsis and its other causes. So how we treat these patients of the meningococcal meningitis? We are to use the penicillin G, and we use in 24 million unit in the 24 hours, and the dose is divided every 4 hourly IV, or we may give 4 gram penicillin G after every 4 hours IV. All those patients who are either allergic to penicillin G, or they do not tolerate, or they have got the resistance, or they are suffering from other gram negative meningitis, or meningitis is because of the Haemophilus influenza. In those cases, we use the third generation cephalosporin, which is ceftriaxone. We give it in a dosage of the 2 gram IV twice a day, and the duration depends upon that at least 5 days should have passed when the patient had become the afebrile. So this is the treatment of the patient. But what is how to prevent these patients? As I already told, 40% of these patients are nasopharyngeal carrier. In those patients, we can use the rifampin 600 milligram twice a day for 2 days. We have also the option of the ceftriaxone 250 milligram intramuscular single shot, and we do have the option of use of the ciprofloxacin tablet 500 milligram single dose. So these are the preventions for those who have got the nasopharyngeal carriage of the Neisseria meningitidis. Otherwise, there are vaccinations program. For example, we have two main broad categories of the vaccines to prevent the problem. One group of the vaccines hits the serogroups A, C, Y, and W135. There are two vaccines in this very group. One is known as the meningococcal polysaccharide vaccine, or MPSV4, which is given to the patient who are older than 55 years. But in majority of the patients, we use the second subcategory, which is meningococcal conjugate vaccine, or MCV4, which is used in the patients of the age 2 years to 54 years. And how we give this vaccine to these patients, because this group contains the number of the patients or the persons who are also to enter into the colleges. We give at an first dose is given, it's a 2-dose strategy. First dose is given at the age of 11 to 12 years, and the second booster is given at the age of 16 years. Now, those vaccines which target the serogroup B, or whenever there is an epidemic of the meningococcal meningitis at the hands of the serogroup B, we have two group of the vaccines. One is the Men B FHBP. This is the name of the vaccine. The second vaccine which is used against the serogroup B is the Men 4C. Now, these are used in the age group of the 10 to 25 years of the age, especially in those patients who are into the epidemic of the serogroup B and who are susceptible. So, all the susceptible people are given these vaccines. Now, it was a summary of the disease. Now, once we have done the summary of the disease, let's put these on. So, meningococcal meningitis is caused by the Neisseria meningitis, which is a intracellular gram-negative diplococcus, and it has got 5 serogroups or 5 strains: A, B, C, Y, and W135. B is responsible for cases on and off, but C is the most common cause of the epidemics. Now, these are spread by the droplet. It's a droplet infection, the transmission, and meaning it can cause either of the three situations: meningococcemia with the sepsis, and there will be no meningitis; meningococcemia with meningitis, and sometimes only the meningitis. It's the inflammation of the meninges. Now, what are the group of the patient which are at risk of developing the meningococcal meningitis? It can be the military recruits and the hostiles, because they both of these groups, they live in the closed environment. So if one person develops the problem or carries the problem with it, there is a easy spread to the other, because spread is through the droplet. It's a very easy transmission. Those people who are traveler and who travel to the epidemic or endemic areas, microbiologists who are exposed to the Neisseria meningitis, and those patients who have anatomical or functional absence of the spleen, and those people who are deficient in the complement level. Talking about the clinical features of the patient, these patient presents with these symptoms. Patient may be nauseous, patient may be vomiting, patient may feel pain abdomen. It can also be the pain in the body, in the limbs, and in the back. Patient may be confused, has a high grade fever with chills. Sometimes these patients are confused or also develop the fits and ultimately go into the coma. And there are certain signs which we check in these patients. One is the kerning signs. What we do in the kerning sign, that we first flex the hip of the patient at 90 degree, and then we extend the knee joint, and patient feels pain in the hamstring. It reflects the meningeal irritation. This is known as the kerning sign, and it should be positive in meningococcal meningitis. In case of the Brudzinski sign, when we flex the neck of the patient, there will be an automatic flexion of the knee joint. This is known as the positive Brudzinski sign. And again, we look for the red spots, which can be small in size. We call it the petechia, and especially on the lower limbs and pressure points. But when they are larger one, we call it the ecchymosis, and sometimes they slough off and they start the gangrene. So these are the sign and symptoms in these patients. Talking about how to diagnose these patients of the meningococcal meningitis, obviously the clinical scenario is one of the most important entity of the diagnosis. And other than the clinical diagnosis or scenario, we go for the lumbar puncture, and we take out the CSF, which is turbid or cloudy or whitish in color in majority of these cases. There is a high opening pressure, and when we analyze the CSF under the microscope, there is higher protein concentration because of the presence of the Neisseria meningitis, and because of they use the glucose, so the glucose level is on the lower side. There is a higher WBC or total leukocyte count in the CSF, which goes higher than the 1000 cells per cubic microliter, and majority of these are the polymorphonuclear or the neutrophils. Because the Neisseria meningitis is an intracellular gram-negative diplococcus, so we may find the bug in these cells. We also do the gram stain and culture of the CSF and also other excretions, including the ecchymotic excretions. Then we can also find the organism there by the latex agglutination test. We do the CT scan and MRI of the patient to exclude other causes of the encephalopathy or alteration of the sensorium, because it may be a case of the mass lesion. We do the LFT and serum ammonia to rule the hepatic encephalopathy, and we check the PT, APTT, INR, because majority of these patients also develop the disseminated intravascular coagulation, where we see the alteration in the clotting factors. Now, once we have diagnosed the case as a meningococcal meningitis, we need to start the antibiotics very immediately, because when the patient presents, we do not know if the patient is a case of sepsis, so we take the blood cultures to rule out the sepsis, but we immediately start the antibiotic. We do not wait for the lumbar culture. We do not wait for the CT scan or MRI. This is such an important point to remember, that you need to immediately start the antibiotic that will make the real difference between the life and death. So the first choice is the penicillin G if patient is not penicillin allergic. We give the penicillin G intravenous, 24 million in the 24 hours, and this dose is divided every 4 hourly. That means we will give every 4 hourly 4 million units, 6 doses. So in total it will be 24 million units. But all those patients who are either allergic to penicillin, or they have developed a resistance towards the penicillin, or they are gram-negative meningoencephalitis. Other than this, like meningoencephalitis, they can be a gram-negative organism meningitis, or the meningitis is because of the Haemophilus influenza. In all those cases, we give injection ceftriaxone 2 gram IV twice a day. Now, the duration is very important, that full dose antibiotic IV should be given to the patient as long as patient is not afebrile for at least 5 days. Otherwise, there are short courses, especially in cases of the ceftriaxone, that you can give 4 to 7 days. But giving these antibiotics to these patients is very important. As we all know that prevention is always better than the cure, so there are vaccination programs which prevent the development of the disease or spread of the disease on the first place. So how many vaccines we have got? There are 4 categories of the vaccine. The first one is the meningococcal polysaccharide vaccine, which we call the MPSV4. It is given in those patients who are more than 55 years of age, and it is used against the serogroups of A, C, Y and W135. The second in this category, which is used against the serogroups A, C, Y, W135, is the meningococcal conjugate vaccine, which we call the MCV4. This is the one of the most used vaccine. Why? Because it targets an age group of 2 years to 54 years. So in all those patients who are in the pre-adolescent age, the first dose is given at around 11 to 12 years, and second is given before they enter into the colleges, so around the 16 years of age or 15 years of age. So, and there are 2 more vaccines which target the serogroup B. These are the Men-B FHBP and Men-B 4C. Both of these are given in those epidemics which are caused by the serogroup or the strain of the Neisseria meningitis serogroup B, and it targets the age of 10 to 25 years. These vaccines are also very important in all those patients who are either functionally or anatomically asplenic, or they have complement deficiency, or they are working in the high risk environments, like if the microbiologists who are very much exposed to the Neisseria meningitis, or a healthcare worker who has done mouth to mouth resuscitation of a patient of the meningococcal meningitis, or those people who are living in the army centers, and who the persons who are living in the hostels, or all are these the high risk patients, and they definitely need the prevention with the help of these vaccines. We had already talked about it, that 40% of the population is carrying the Neisseria meningitis in their nasopharynx, and only a few of them will go on to develop the infection itself. But if we want to prevent that development of the infection, there is a way to do it. We can give rifampin in these patients per orum 600 milligram tablets twice a day for 2 days. That will prevent them from developing the infection. We can give them the tablet ciprofloxacin 500 milligram per orum, only 1 dose, and injection ceftriaxone 250 milligram intramuscular single shot can be given. So these are the 3 ways to prevent the spread of the infection or development of the infection in the carriers of the nasopharyngeal Neisseria meningitis. So that's all about the meningococcal meningitis. This is very important to know something basics about the disease. It's a causative agent, its spread, and how it can be treated, how it can be diagnosed and treated, and how it can be prevented. This is such an important thing because it happens sometime in the society that there is an epidemic of the meningococcal meningitis. And thank you very much for watching the video. If you like the video, then please subscribe the channel and press the bell icon and help me grow the channel. Thank you so much once more.